remember, I don't know why, when you said before that like the brain still functions for a while, are you familiar with that old legend of Antoine Lavoisier or whatever his name is? Or, known as the father of modern chemistry?
No. Go ahead.
Oh, boy. All right. You're in for a quick little treat.
Okay, folks,
So,
talk along. Hey, everybody. Welcome back to Monday Afternoon Journal Club. I'm Dan Schwester, and I'm with Kevin Mazza.
That's me.
Yeah, Ed's on the truck today, so he is gallivanting around the area, treating people and making friends. And so Kevin and I have decided we're going to do Journal Club. And Kevin came up with a really, really interesting article that has a lot of implications, I think, in future care and also how we treat patients right now. It is out of the New England Journal of Medicine, and it came out August 15th. So this is a 4-day-old article, and the title was Cognitive Motor Dissociation and Disorders of Consciousness. It is Bodian et al. And basically, this is a paper that shows that your patient may be unresponsive, but they are a lot more understanding and a lot more cognitively there than we previously thought. And again, this is something that has real implications for everybody, from the EMT level all the way up to paramedic to the flight world, critical care transport. So Kevin, you're the one, you really did a deep dive on this over the last couple of days. Take us through it and talk about the nuts and bolts of this and what you got from it.
All right. So, yeah, I had some time to read it. So, a quick look at the numbers. It's a convenient sample of 353 adults with disorders of consciousness, specifically something they call cognitive motor dissociation. It was an international study taken from places that can handle these patients, and I'll get more about these patients in a second. And it's about basically the presence or absence of an observable response to commands when assessed using the coma recovery scale and the revised one. And basically, these patients were looked at. They were giving verbal commands or external stimuli while under functional MRI or during an EEG. So what the coma recovery scale revised is, it's just like an auditory, visual, motor function, oromotor or speaking, ability to effectively communicate, and arousal scale. Quick, and these typically happen about 12 months after injury. 12 months after injury. Why are we talking about this? Because we talk about EMS. We'll get to that. So quick look at the methods. 6 multinational sites contributed behavioral and task based on, again, functional MRI, EEG, or both. Yeah. And all kind of kept in the REDCap 20 database. And all this was collected from 2006 to 2023. So big data points. The median age at the time of injury was 33.8 years old, ranging from 22 to 54.
Pretty young.
Why that's important is it kind of narrows down who they're looking at. People typically probably not a lot of comorbidities, who have other extraneous or other what's the opposite of extraneous? Intraneous? Have other comorbid factors that would affect their...
Overrun.
You don't have the elderly brain atrophy. They're on a bunch of meds at the time of injury.
Yeah, these are not people that have, cognitive deficits from dementia or Lewy body issues or things that normally cause a degradation of those functions.
Yeah, so we're talking like 22 to 55, right. Like pretty much healthy adults. And then the median time from injury to the coma recovery, I'm just call it CRS, was about 12 months. So a year after injury.
Okay.
None of them they've all been in prolonged coma greater than 3 months because the ranges are about 3.5 months to about 57 months total. So long-term, persistent vegetative state, minimally conscious patients. So we already know, and a majority of these patients were from brain injury, so roughly half of them. The rest were from hypoxic episodes, post-cardiac arrest, stroke, and then the rest was like kind of other.
Okay, but mostly TBIs because these are people that were fine on Friday and now Saturday, boom.
Big time traumatic brain injury is like because this is what causes these kind of long-term coma states.
Okay.
So why are we talking about that in EMS? Well, we already know that cognitive motor dissociation is present in about 10 to 20% of our acute brain injury patients. So what exactly is cognitive motor dissociation? Well, if you don't know, now you're going to know, is basically when you have an unresponsive patient, that might not mean that they're entirely unconscious. What's that mean? So I don't know about the rest of you, but things can get a little loose-lipped on scenes when you have an unresponsive patient. You might be saying things like, this patient is not going to do well, or you might be talking smack about their family, or just not even in care at the moment. According to the study, roughly 25% of those patients in this study could hear you and react to you. We know 10 to 20% in EMS, acute injuries do that already.
Right.
So this just kind of hammers home that not only does it happen acutely, but it remains that way for a long time. So if somebody just got knocked out and you got there within 20 minutes, trust me, they're still going to be hearing you about 30 minutes later when you get to the trauma center. So we can't detect cognitive motor dissociation in the field, right? We don't have functional MRIs, we don't have EEGs, we don't have CT scans, anything.
Right.
You should be assuming that every single patient can hear you, regardless of their status. There's anecdotal stories of people who were in cardiac arrest and they could hear the staff during the resuscitation, and then they recovered and they remembered it.
Yeah, I've heard the similar stories that, like the person who was, out on the ground or flat on their back, GCS of 3, and you're looking at them and going, wow, they're screwed. And those people recover and they would tell you that. Also, the important thing too to realize is, even if they don't recover, you're causing psychological stress to your patient by not acknowledging that they are there, that they are aware, and that they may be able to process what you're telling them. So think about, like, what I'm thinking about is invasive procedures. Like, that person is not just a meat sack. That person is actually somebody who knows what's going on. Even with this disability, they may be able to process it. And that really spells out a need why your patients really need to have good sedation, good pain management. Even if they're a GCS of 3, the pearl I took from this was, you really need to consider their brain and their processing.
Absolutely. And the article actually addresses this too, and I'll quote it. Identifying a patient who otherwise appears to be unconscious has the capacity for cognitive processing. We can mitigate emotional harm when the patient's clinical team and family recognize that the patient is aware and treat the patient as such. So we can't detect it in the field, obviously, like we just said. Right. So you gotta always treat every single patient this way, because that's just, one, it's the right thing to do. It's a human being you're talking to.
Mm-hmm.
And the good news, in my opinion, is in EMS, we actually do a pretty good job of properly treating these patients who might be aware. They get proper pain management, they get proper sedation, and they get proper treatment and transport.
Mm-hmm.
We have to remember about our loose lips, though. When we've done all that, it doesn't mean that they can't hear or feel you in the moment, right? We've got hypnotics and sedatives between ketamine, Versed, etomidate.
Sure.
They may not remember it because of these drugs, but it doesn't mean you're not causing emotional harm in the moment, which could severely affect their long-term clinical outcome, right?
Right.
Talking about, saying you have a patient who's like a severe trauma, and you've RSI'd them, you've given everything, and you're like, oh man, this patient's like effed, like they're not going to make it. This dude's effing screwed, bro,
Yeah.
That patient can hear you, and their patient just, you've broken their spirit, even though they can hear you. Their brains,
and right, and we don't know the mental aspect of healing yet. We're not that good that we figured out that correlation, right? So is it possible, from reading this study and thinking about how people respond, that, if you're doing that, like, oh, they're screwed. This is a waste of time. We're wasting our time here. Could you actually be hurting the patient? And this tends to suggest that maybe you could. It definitely reinforces for me the need to, even if your patient's unconscious, talk to your patient, tell them what you're going to do, just like you would with a conscious patient.
Right.
If they have a bad injury, or even if you don't think the injury is survivable, you need to be aware of their brain and what's left of their brain and what's able to be functional. And
Right.
just for the people that don't, or maybe the new EMTs and stuff like that, functional MRI is kind of interesting because it's a real time representation of what stimuli lights up what part of the brain. It's actually pretty cool. I myself, I've never seen one. I'm not really sure how specifically it works. I'd have to look it up. However, it does a very good job, and it's pretty accepted in the scientific community that if you're doing stuff in an FM in a functional MRI, you can tell what part of the brain is functioning based on the stimuli they're receiving. Um,
Mhm.
I think there was actually a Grey's Anatomy on this where they were like doing it in the
Oh,
MRI or something, and
probably, but I'm
but
an
you get
adult,
the
so I didn't watch
idea, right? It actually works. And EEG is the same way, but just not as graphically indicated. Here
it.
with
Right.
an EEG, it's almost like an EKG, but the electrodes are on your head and you're measuring brain waves as little electrical impulses, and you can see where they light up on what electrode. And neurologists and neuroscientists understand, like, hey, that squiggle means this, that squiggle means this.
Quite literally, you could see it light up. Like, and
Yeah.
even in the paper, they do have the references to go to the studies where they have normal, cognitively normal people under functional MRI and stimulating them in certain ways to see where in their brain is activated.
Right.
So they have a basis for what normal should look like.
Mm-hmm.
Uh, and going back to like how to treat these patients, like I said, we do well, and critical care does really well. But a lot of times you'll go in and you'll see an unconscious patient, especially if you're like a critical care transport team, EMT, medic, nurse, otherwise.
Mm-hmm.
You see them like you have an intubated subarachnoid hemorrhage who's unresponsive and they're only on like propofol. Propofol is a sedative.
Right.
They need pain management also. And we go my program goes through a lot of fentanyl because we go into a lot of places and we take a lot of these patients and they are not adequately pain managed.
Right.
And I can only speak from anecdotal experience, but I've even found that once I've performed my procedures and actually talked to the patient like a therapeutic manner, I've seen like their heart rates come down,
Hmm.
their blood pressure seems normal. They can still hear you, and their body can still react. They can still have like adrenaline release or cortisol release, and all the other things that really do damage. Like there's countless studies on how cortisol affects brains, right?
Yeah.
A little therapeutic communication, like just like you would talk to with a live patient, goes like kind of a long way.
Mm-hmm.
And I've made it a habit to talk to my like it used to be kind of funny to me. Like I tell like my unresponsive patient to hold still for the 12 lead. Like in retrospect, like kind of going further than that, but like, hey, listen, I'm performing a 12 lead. I'm taking a look at your heart. That's a good habit for anybody you're treating
Mm-hmm.
because Danny and I were just talking before. Like, could you imagine starting an IV on somebody where you don't warn them and they pull back and you get mad at them when it like the IV misses? Like, you didn't warn them. That's ridiculous.
Right.
So if you're about to place a tube down somebody's throat who's unresponsive, like, you could say real quick, like, all right, Mr. Blah, 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 we're going to be placing a tube down your throat. If you feel this, don't be alarmed.
Mm-hmm.
We're going to medicate you ahead of time.
Yeah.
It'll be all part of like your pregame. It takes seconds. I brief all my I brief all of my unresponsive patients for flight, even though they can't hear. They all still get hearing protection, even though they can't hear, because they're still vulnerable to stimuli. And that's a way, not to preach, but like we should be treating all of our patients, regardless of their mental status, this way, as if they're fully alert and oriented, and they need to know what you're doing for their own well-being.
Yeah, I think that's really important. And, it's the little things. You hear so many times in medicine, people are like, oh, it's the little things that matter. It's this. These are the little things, right? These are the things that don't spend a lot. It doesn't cost you a lot of effort to do it. It doesn't cost you a lot of time. It's, yeah, but we don't have time to do this. Like, you do have time to do
You
this.
have time.
We always have time to do these things. We always have time to talk to people. There's other studies out there that I read something and I have to look it up, but it says something like hearing in cardiac arrest is the last thing to go as you die. So you still hear what's going on.
Mm-hmm.
Obviously nobody's done a study of hearing acuity during cardiac standstill, But
Very hard to
the
do.
point remains, as the brain's dying or as the brain is injured, it can still function, right? And we need to be cognizant of this. We need to take care of these people just like we would of an awake person. I'm not saying you got to sit there and be the coma whisperer, but just common courtesy, common decency goes a long way to, number one, probably making that patient feel better in some way, and also making yourself feel better because you're in a very unnatural situation. You're dealing with somebody who's probably had a catastrophic injury or a catastrophic, damage to a vital part of their organ of their body, what makes them them. Don't think for a second there isn't like a little thing that kind of affects you. And if you tend to treat people as not human, I wonder if you tend to become not human. And
Right. I mean, you gaze too long in the abyss, and the abyss stares back at you.
I knew you were going to come up with that. I knew you were going to come back with that.
Be careful when fighting monsters, for you'll become a monster yourself.
Yeah, absolutely. And I think it's a really good paper. Again, I think it's something that everybody should read, and pay attention to. I think it should be taught in medic schools. I think it should be taught in EMT school. These people are cogniting. They are processing things. We don't know how they're doing it. We don't know what they're doing, but they are doing it. And that means sedation, pain management, therapeutic communication. All of these things actually matter, even if their GCS is 3.
I think I'm just going to make like a hat or a t-shirt that just has like sedation does not equal pain management.
That's another thing that we need to, that really does need to be talked about. And again, I think you're right with EMS because we protocolized a lot of this stuff. It's not,
but that helps us get it right? We protocolize it where we have a set thing we're going to do where we can't, because it needs to be done, right?
Yeah.
And also, pain management is not sedation. A fentanyl drip on an intubated patient as the only form of sedation is not appropriate either.
I mean, it will make them a little sleepy, let's be honest. It will give them a little bit of something, but it's certainly not. And somebody who's on an effective pain management regimen, and I'm sure you've seen this in the critical care world, where you go into an ICU and you've got a patient who's on a fentanyl drip and their pain is well managed from that, from that tube being in their throat. They don't need a ton of sedation. They need good, effective pain management and little drips of sedation, little pushes just to kind of keep things cool, right?
Yeah. You remember when we went to the MCRIT conference years ago in New York?
Yeah.
One thing I really took away from Weingart, for your intubated patients, you want to get them obviously not paralyzed, but on the least amount of sedation as possible.
Right.
That's always your goal. As little sedation as possible. And that's like something I've always kind of carried with me. Whether or not he backed it with evidence, I don't know. I'm sure he did. It's Scott Weingart. But I don't know why it always stuck with me for all these years. And the least amount of sedation to make the patient manage comfortable and managed well is the goal, right? Just loading them up and just keeping them out in a medical coma and intubated and always paralyzed is not good.
No. And
not a good way.
And the studies seem to show that you get ICU delirium, you get, there's more ventilator days. They don't do as well in the ICU as opposed to somebody who has their pain and discomfort managed, and maybe they're on a light dose of propofol, just kind of keep them a little foggy, a little cotton candy haze. And the nice
cooperative.
What's that?
Cooperative but rousable. You do something like the RAS scale, RAS, rousable agitation scale.
Yeah, and that's why especially if you're in a system that has the ability to use it, propofol's a great drug, right? Because it's quick on, it's quick off. You can shut it off, and these people will wake up and they will be able to talk to you, able to communicate. Yeah. If they're uncomfortable or they get agitated, you turn it up a little bit and they go back to a nice score. RAS scale is something worth looking up because it goes from +5 to -5. It's a really good objective score, especially for the critical care transport world. I don't use it much on the ground, but I can see if you have a flight where you're taking somebody a fair distance, where the doc can say, hey, I want you to keep them at a -2. Hey, I want you to keep them -1 because this is what I'm looking to do. It gives you and your nurse partner a real good idea of where you need to be.
Yeah, and it's a good scale to use to kind of titrate back and forth, and kind of like getting away from the study here a bit, but like kind of wrap it back in. Dan, remember, I don't know why, when you said before that like the brain still functions for a while, are you familiar with that old legend of Antoine Lavoisier or whatever his name is, or known as the father of modern chemistry?
No. Go ahead.
Oh boy, all right, you're in for a quick little treat.
Okay, folks,
So
buckle up.
he was guillotined in 1794.
Ah,
But apparently, according to legend, his last experiment was to see how many times he could blink his eyes after he was decapitated to show how long his brain was functioning. Allegedly, he blinked 15 to 20 times.
no.
Yeah. So my guess would be the oxygen reserves in his brain, if it's true,
Right.
allowed him to perform the blinking. And I actually, it traumatized me as a kid because the Discovery Channel did a dramatization of that, and it basically showed like a head kind of falling in the basket, and then you just see the eyes through the weaving just going like this.
Wow.
It messed me up a little
That's
bit, but and here I am talking about it now as a 38-year-old man.
Lovely. So anyway, guillotined heads of the bourgeoisie aside, this I think is a really
I took this off the rails.
It's a new paper. It is brand new out in the New England Journal of Medicine. It's definitely something that if you have the opportunity to, please take a look. We'll link to the PubMed in the show notes. I think it's really something that backs up when, you hear somebody who says, they're just this, they're just that. Yeah. You can point them to this and say, no, they may not be what you think they are. They may be a lot more aware or a lot more able to process.
Yeah, remember, we already knew before this that 10 to 20% in acute brain injuries are still conscious but unresponsive.
Right.
So we knew that already.
Yeah. So this is important because it's scientific evidence that really backs that up. It definitely is something if you're looking to talk to your medical director about your sedation or your pain management guidelines, definitely something to consider, because especially if you have a system where they're like, well, GCS of 3, you don't have to do anything for them. You might have to. So this is something to bring it up. So this has been Monday Afternoon Journal Club. Again, like, comment, subscribe. The button Ed tells me is
smash that subscribe button.
It's somewhere over here. I have no idea. I don't see it. Ed just told me to make sure that everybody mashes it. And we will be back next week with another Journal Club. And for the Overrun, I'm Dan Schwester.
I'm Kevin Mazza. Remember, treat your unresponsive patients well, even the ones that are recently decapitated.
Watch out for those guillotines, folks. See you later.
Get home safe, everybody.